Good morning, everyone. I'll be speaking on keratoplasty techniques in keratoconus. I have no financial disclosures to make. So if we talk about the treatment of keratoconus, it started with glasses or RGPs in early cases. When the disease is progressing, we need to do collagen cross-linking. And once the disease is stabilized, we can do intacts. Other treatments are toric ICL or RGP lenses. And if nothing works, then we have to go for lamellar keratoplasties. And if that also fails, we have to go for PKP or the new involvement of femtosecond for the keratoplasties. So if we talk about the challenges of keratoplasty in keratoconus cases, most of the patients were young, so they have a natural clear lens, so we have to save the lens while the surgery. Most of the patients have high astigmatism pre-op, and after surgery also they have a high astigmatism, so we have to take care of the astigmatism. Patients are young, so they need early recovery. They have a lot of expectations from the surgeon, and cosmetic appearance is also a concern. So this is a video showing the case of advanced keratoconus. So I decided to do a lamellar keratoplasty in this case. So we can see there is an inferior cone, and this is a case of VKC. So we can see superiorly there is a lot of allergic signs. So after measuring the graft size, I did the partial trephination. Then I went for the lamellar dissection with the crescent. And after dissection, I got a clear cornea, but I was not satisfied. And then I did the intra-op pachymetry, and it was showing around 160 micron. So 160 micron, so I thought it's still not sufficient. So I made a side port and put some bubble in the IAC and tried big bubble technique. And as soon as the air entered, the big bubble came, but it gave way from the cone area. So now I was not sure what to do now. Then I put some visco on the top of the cone and opened the air bubble, but it was a big perforation. So I need to convert. What went wrong in the lamellar keratoplasty, Dr. 𝐁𝐨𝐸𝐽 will explain in the next talk. Then after converting into the penetrating keratoplasty, I did a suturing. It was 16-10-0 nylon sutures. One thing that is important in keratoconus keratoplasty, the graft and the host size should be same. We should not take bigger graft because it's already ectatic. So we have to take same size graft so that the host of astigmatism is less. So coming to the femtosecond lasers in ophthalmology, it has come to the femtocataract, femtoLASIK, femtointacts, and now femtokeratoplasty. So femtosecond is based on the principle of photodisruption. So various laser pulses are connected together in a raster pattern to create a dissection plane. And then these laser patterns are also act vertically to make a cleavage plane. So these gas and water bubbles of femtosecond make a complete resection, and we have to open it. So why femtosecond laser? Because it permits full thickness graft with a peripheral lamellar wound configuration. The femtosecond laser has the ability to perform incision of any angle at various depth within the corneal tissue. It also increases the surface area for the stromal healing. The femtosecond laser has a greater precision, finite control, and in an automated manner. In this technique, there is a minimal donor tissue manipulation, so less endothelial cell loss. So these are the various platforms available with the femtosecond laser with the Abbott Medical Optics, with Alcon, Carl Zeiss, Bausch & Lomb, and Zimmer. These are the machines. So what is the extra edge with the femtosecond laser? A manual PK wound is usually vertical, but with variation from this type of wound construction is not possible in the manual keratoplasty. Whereas in femtosecond, we have different options like top hat, mushroom, zigzag, and Christmas tree pattern. So now what type of incision is best for what case? So for top hat, like in top hat shape, there is it removes less stromal tissue and more abnormal endothelial tissue. So it is suitable in pseudophakic bullous keratopathy cases. Whereas in keratoconus cases, mushroom shape is best because it removes more abnormal stromal tissue and saves more of the healthy endothelial tissue. So this is a cross-sectional image. First of all, the laser cuts the make the posterior cut, then it makes the, this is the posterior side cut. First it makes the posterior side cut, then it makes a ring lamellar cut in a planar manner, then it makes the anterior side cut. So these are the settings for the donor and the recipient. We have to make a ledge of around 1.5 millimeter so that the suturing will be in the ledge area and the effect of the sutures won't go to the donor area. So this is a video of the femtokeratoplasty. First of all, we have to feed the values in the machine. Then this is a donor cornea. We have to mount it on the anterior chamber. Then this femtosecond laser cuts the cornea in a desired shape. It takes just 5 to 7 seconds to cut the donor cornea. And simply you can lift the donor cornea. Similarly on the patient, after docking, the laser will cut the recipient cornea. And it's ready for the suturing now. So suturing can be 16 or 12, or we have tried 8 sutures with fibrin adhesive. It works well. So this was the case of 19-year-old female with advanced keratoconus with best corrected visual acuity of 6/60. We did the femtokeratoplasty, and at 1 month post-op, the uncorrected visual acuity was 612 and BCV was 6.9 with minus 2.5 cylinder. So this is a study published by the Dr. Yatish. So it shows a pre-operative and post-operative is spherical equivalent. So it was pre-operative was 7.38, whereas after 10 months, spherical equivalent goes down to 1.51. And this was a 3 months post-op ASOCT, showing the nice attachment of the donor and the recipient. So now people have tried the femtosecond enabled DLK. In this, we have to do ASOCT of the recipient, and we have to cut less than 100 micron of the thinnest pachymetry. Then we can try big bubble, or if the surface is clear, we can suture the donor. So if we talk about the advantage, it allows for a programmable cut pattern. There is a variety of shapes possible, precise dimensions. There is an exact match between the donor and the host is possible. Greater preservation of the endothelium because less manipulation is required. So in conclusion, keratoplasty is the last weapon to manage advanced cases of keratoconus. Success rates are encouraging in keratoconus cases. DLK should be the first choice if going for keratoplasty. And femtosecond laser gave the new dimensions for two keratoplasty techniques. So I can say when nothing works, keratoplasty works. Thank you.